people have joined ना पुनीत?
Yes sir, people have joined sir.
ठीक है, कितने लोग ज्वाइन किए?
So at the moment 15 including all of us sir.
चलो
Usually around 20-25 होते हैं.
चलो कोई बात नहीं. So अभिषेक फिर स्टार्ट करो हैं. So good evening everyone, and today's bedside Dr. Abhishek is going to present, and what we will be going to do is presentation in 15 minutes, and then we will discuss about the diagnosis and then discussion about what is the problem with the patient. Okay, so we will finish it up in 1 hour. So, okay, Abhishek, please start.
Thank you, sir. So good evening to all of you. I am presenting the case of Miss S, a 32-year female, a resident of Delhi. She has a bachelor's in computer science. She's a homemaker. History is provided by self and is reliable. She was admitted in the hospital 5th of January.
Just a second, Abhishek. Dr. Manu has joined.
Oh,
Dr. Manu, good evening. I can see Dr. Dogra. I think you are muted, Dr. Dogra.
सर हो गया, अनम्यूट हो गया सर.
Unmute. Good evening and welcome.
Good evening, sir. Sir, थोड़ा
And
internet.
it's always nice to have a bedside with you
Sir,
as the examiner.
Sir.
So okay, Abhishek is my student.
Sir.
I want you to start, and then in between I will also be asking. Okay? So you start the case.
Sir. Yes, sir. Start
So,
Abhishek.
Start karo aap.
Start Abhishek.
Good evening, sir. Sir, I am presenting the case of Miss S, a 32-year female resident of Delhi. She is a bachelor's in computer sciences. She is a homemaker. History is provided by self and it is reliable. She was admitted on the 5th of January and was examined on the 14th of January. So presenting complaints, the patient is a known case of chronic kidney disease stage 5 on maintenance hemodialysis, admitted for renal transplant surgery. So the history of present illness. So the history of my patient starts around 7 years back in 2014 when she became pregnant for the first time. She was a booked case on regular antenatal visits, and her first 2 trimesters were uneventful. During the 7th month of her pregnancy, she was told to have a high blood pressure. She does not remember the values. There is no history of any swelling over face or feet, no history of breathlessness, blurred vision, headache, or seizures, no history of yellowish discoloration of eyes and urine, or pain upper abdomen. There is no history of passage of any frothy urine or cola-colored urine or frank hematuria, no history of reduction in urine volume or any abnormal serum creatinine reports. The hypertension, it was managed by a single drug, and she underwent elective LSCS at 39th week for raised blood pressure, and she delivered a healthy baby boy of normal weight. She doesn't remember the actual weight, with an uneventful post-op period. She was discharged soon after, and over the next 1 month, her antihypertensives were discontinued. She did not follow up further, and nor did she record any blood pressure for the next 3 years. When in 2017, she became pregnant again and was found to have raised blood pressure at the first antenatal checkup. She remembers her systolic BP being in the high 130s and diastolic blood pressure being in the 90s. She was started on a single blood pressure medication. There was no history of any swelling over face, feet, any breathlessness, headaches, jaundice, any proteinuria or hematuria during the course of pregnancy till the 9th month. In the 9th month of pregnancy, her blood pressure recordings were high. She remembers the diastolic blood pressure to be 106 millimeters of mercury. Subsequently, the antihypertensive drugs were increased. She remembers that in the 9th month, on routine evaluation, her creatinine was found to be of 0.87 milligram per deciliter, which progressively increased to 1.3 milligram per deciliter over the next 2 weeks. And there was a fall in her urine output. At this time, an ultrasound abdomen was done, uh, after which she was told that her kidneys were affected, though they were normal sized. A nephrology consultation was done, and she underwent an LSCS at term, delivering again a healthy baby boy with normal birth weight. Now, over the next 3 weeks, she was on routine follow up. Her urine output increased, her blood pressure reduced, but the antihypertensive medications had to be continued, and the serum creatinine stabilized at around 1.2 milligram per deciliter. At this point, a renal biopsy was done. Based on the report, she was told to have advanced kidney disease and asked to continue BP medicines and follow dietary advice, including a low salt and low protein diet.
When was the biopsy done? In which year?
Sir, this was in 2017,
Okay.
around 3 weeks after
Delivery.
Sir.
Okay.
Sir, there is no history of any fever, weight loss, any joint pains, rashes over body, any oral ulcers, hair falls, redness over eyes, no history of any cough, breathlessness, pain, abdomen or chest pain, no history of any swelling over face or feet, passage of frothy urine, cola colored urine, and hematuria, especially that associated with any upper respiratory infections in the past. There is no history of intake of any painkillers, indigenous medicines. There is no history of any recurrent UTIs. Over the next 2 years, her antihypertensives had to be increased from single drug to 3 drugs, and her serum creatinine, it progressively increased to 5 milligram per deciliter till by December 2018. In January 2019, she had an episode of fever, which was high grade, not associated with chills or rigors, or any cough, diarrhea, dysuria, or pain abdomen. This fever was associated with a rise in serum creatinine and a reduction in urine output. There was no history of any altered sleep or behavior or convulsions, no history of any chest pain or palpitation. She was admitted for the same and evaluated. She was treated with IV antibiotics. Subsequently, she was started on hemodialysis, and 2 sessions of dialysis were done. Hemodialysis were done through cannula in her leg. Over time, the fever resolved, and she was counseled to continue with hemodialysis and explained about transplant. The options for vascular access in the arm was given, but she opted for a catheter in the neck with some part of which was burrowed in the skin, and she was started on maintenance hemodialysis twice weekly. During the course in dialysis in June 2019, she had uncontrolled blood pressure during dialysis session. Her antihypertensive medications were increased to 4 with double doses of 2 drugs. Her hemodialysis frequency was increased to 3 per week, and she was asked to keep strict salt and fluid intake. The raised blood pressure, it resolved over a period of 2 months, and she was switched back to twice weekly dialysis and again 2 antihypertensive drugs. In September 2020, she had an episode of chills during hemodialysis. The cultures were sent from her dialysis catheter, and she was diagnosed to have infection in the dialysis catheter. She was admitted and treated with IV antibiotics for 2 weeks, and the infection resolved, and the catheter was left in place. There is no history of any intradialytic hypotension, no history of muscle cramps, any palpitations, no history of any fatigue, any dyspnea or exertion, bony pains or back pain. She has not been vaccinated for any hepatitis B or pneumococcal or influenza vaccines. Her residual urine output has reduced from 1 liter 200 ml over the past 2 years on dialysis. Her husband volunteered for transplant as donor and was worked up. After cardiology and gynecology workup, she was cleared and admitted for transplant surgery on the 5th of January. On the day of admission, she was given 2 medicines which she was told would help her to take up the transplant. On the next day, hemodialysis was done, and she was given two medicines through infusions for her transplant. Surgery was done on the 7th, and immediate post-op period was uneventful, though she has no recall of any events in that period. Her creatinine, it
Will hold on over here.
0.8 milligrams per deciliter by the fifth day of by the fifth post-op day, and she remembers an ultrasound done, which she was told was normal. She required one antihypertensive for control of her blood pressure till the fifth day. However, she was told that the level of one of the transplant medicines was low. On the sixth post-op day, her BP had risen, and one more drug for control of blood pressure was added. She had an episode of fever documented at 100 degrees Fahrenheit, not associated with any chills and rigors, and was relieved by paracetamol. There was no cough, pain, abdominal. There was no cough or diarrhea.
Abhishek, can we hold it here?
A complaint of right lower abdominal pain in the stitches on the post-op day 6. This was continuous throbbing. There were no aggravating factors, and it was relieved by pain medication.
Abhishek, can we hold it here?
Cultures were sent from her blood and urine. Her antibiotics were added, and both the dialysis catheter and Foley's catheter were removed. On
Abhishek, can we hold it here?
Her serum creatinine had risen to 1.4, and she underwent a repeat ultrasound and was subsequently planned for a renal biopsy.
Abhishek, can we hold it here, please?
I'm sorry, sir.
Can you hear me?
Yes, sir.
Acha, Abhishek, can we hold? It's a very long history. Okay. Can you hear me?
Yes, sir.
Acha, it's a very long history. So we'll start off with the starting.
I'm sorry, sir. I'm not able to hear you.
Okay. I'll just now. Can you hear me now?
Yes, sir. Yes, sir.
Okay. Now we'll start off from the starting.
Sure.
So 2014, she presented with high blood pressure during pregnancy.
Yes, sir.
How do you classify this hypertension? What diagnosis would you fit her in?
Sir, she presented with a raised blood pressure in the 3rd trimester, and she had no features suggestive of any proteinuria, no evidence of any renal dysfunction, hepatic dysfunction, or neurological complication, and she had a normal, healthy voice. So I would classify this as gestational hypertension, sir.
Okay, fine. So, what is the commonest cause of gestational hypertension in the such patients? What is the commonest cause?
Sir,
Tell me one thing. Once her pregnancy, she underwent a cesarean section. Did the blood pressure recover?
Yes, sir. Yes, sir. It recovered in 1 month time. Her antihypertensive was stopped, sir.
Okay. And thereafter, she was absolutely asymptomatic till 2017.
Yes, sir.
When the blood pressure again came up in the 9th month.
No, sir. She did not have any blood pressure recordings during this period, but on her first antenatal checkup in her 2nd pregnancy, she was told to have high blood pressure. And she specifically remembers her diastolic blood pressure being in the 90s and was started on an antihypertensive.
Okay, tell me, what are the hypertensive disorders in pregnancy? How do you classify them?
Sir, hypertensive disorders in pregnancy, sir, they can be classified either as, sir, those appearing before the 20th week, so we classify it as chronic hypertension. Then after 20 weeks of gestation, when it is not associated with any other features, we classify it as gestational hypertension.
Like proteinuria, features like proteinuria.
Yes.
With very specific feature. Okay.
Yes, sir. Features like, sir, then pre-eclampsia, which has hypertension, de novo hypertension after 20 weeks, associated with either proteinuria or any renal, hepatic, neurological dysfunction, or uteroplacental defect, as in leading to IUGR or low birth weight.
How do you classify? How do you define that whenever preeclampsia comes upon a chronic hypertensive patient?
Yes.
In pregnancy, what is the definition like?
Sir, superimposed preeclampsia on chronic hypertension, sir, it can be defined, sir, it occurs either when there is a rise in blood pressure, associated with sir proteinuria or any other sir associated features like renal dysfunction, hepatic or neurological dysfunction superimposed on the chronic hypertension.
Okay. That too after 20 weeks of gestation.
Yes, sir.
Okay. So there's always a risk of end organ damage in such patients.
Yes, sir.
So what all end organ damage do you contemplate in such patient and the history you have taken?
Sir, in patients who have de novo hypertension, sir, there can be sir renal dysfunction, sir hepatic dysfunction with rise in ASTs and ALTs. There can be sir neurological problems and sir hematological abnormalities.
Okay. According to the definition of preeclampsia, how much proteinuria do you should have? So as to
Sir, it
classify as preeclampsia
So 300 milligram per day is the
per day.
cutoff.
Excellent. Or PCR of
Sir, 0.3 milligram per
milligram per
gram of protein.
gram of protein or creatinine?
Sir, 0.3 milligram per gram of creatinine.
And suppose you want to take it as a dipstick. So
Yes,
which
sir.
is significant? How much dipstick protein will be seen in this patient?
Sir, 2 plus
नहीं 300 है तो 1 plus होगा ना? More than 1 plus, ठीक है?
1.
If it's more than 1 plus, then you classify it as वो, ठीक है? What are other features of preeclampsia?
Sir, apart from it can sir preeclampsia can have apart from proteinuria, it can present with frank increase in serum creatinine levels. Sir, it can have hepatic dysfunction with rise in AST and transaminases more than 2 times the upper limit of normal. So neurological features in terms like hyperreflexia and clonus, scintillating scotomas, frank seizures, which is defined as eclampsia. Sir, hematological abnormalities like thrombocytopenia or hemolysis, and sir, IUGR and intrauterine growth retardation.
Chalo, very good. Acha, could it be she had a glomerular disease which was undiagnosed? Is it a possibility?
Yes, sir. It can be quite possible.
Without any proteinuria?
Yes, sir.
Name a disease without proteinuria, glomerular disease, which can cause all these things?
Sir, IgA nephropathy.
IgA nephropathy, some proteinuria will be there. Whenever you have messenger environment,
yes,
there will be some proteinuria, है ना?
Yes.
चलो आगे चलो सर आपकी तरफ से क्वेश्चन सर
Mute, sir. Sir is mute, sir.
Okay. Sir is mute. Chalo Abhishek, continue. Now we come to the,
no questions from my side, Dr. Dogra.
Sir.
I think you have asked all those questions. And I think besides IgA, Abhishek, what underlying glomerular disease you will think of? That was Dr. Dogra's question. So any other possibility?
Sir, it can be a primary and any other primary glomerular disease like sir, FSGS, where sir, not having proteinuria is very rare.
Maybe it was till 2017 when she had second delivery.
Yes.
Maybe it was not there and it developed later, because definitely there was no proteinuria in first pregnancy and second pregnancy even.
Yes.
Okay. Yes.
So now we come to the history of her renal transplant.
Yes.
Okay.
Yes.
Which continue with that. So from where you left, she got she underwent kidney transplant.
Yes,
on
sir. Sir, on the 7th of January.
This year.
Yes, sir.
Okay.
Yes.
Tell us the course after that.
Sir, she underwent renal transplant on the 7th of January. Sir, the immediate post-op period, sir, it was uneventful.
Who was
her,
the donor?
Sir, the donor being husband, it was an ABO compatible transplant. Sir, the immediate post-op period, it was uneventful and creatinine had reduced to 0.8 by post-op day 5. And an ultrasound done on the post-op day 5 was normal, and she was on a single antihypertensive drug in the post-op period, sir. So
Okay.
on the post-op day 6, she had a rise in blood pressure, for which another antihypertensive was added. She had fever recorded at 100 degrees Fahrenheit, and pain in her right lower quadrant along the stitch line. On the post-op day 7, sir, her creatinine had risen to 1.4 milligram per deciliter from 0.8. Repeat ultrasound was done, and she was asked, she was being planned for a renal biopsy on the day of examination.
Okay. So this you finished your history?
Yes, sir. This is my history of present illness.
Okay. What do you think you're going to get on a kidney biopsy in this patient now? Graft biopsy.
Sir, actually, sir, she mentions in her history that she was told that one of the transplant medicine, the level of one of them was low. So it's most probably, sir, this is the tacrolimus that is low. Sir, so with this and with raise in blood pressure and low TAC levels, sir, I expect sir, her to have rejection, possibly.
She is quite a educated lady.
Yes, sir.
Okay. Now our CKD patients, educated CKD patients, they know each and everything about their transplant, including
Yes,
the induction,
yes,
HLA matching, okay, cross match,
yes,
as well as donor specific antibodies.
yes, sir.
Okay. Did you take history of this?
Yes, sir. I asked her regarding the.
You did not mention in your this thing presenting the presentation that I asked leading questions, and being an educated lady, I had taken all that history.
Sorry.
Batao.
Sir, she remembers that the HLA the HLA typing with her husband was 1/6, and there were no her cross match was negative, and there were no donor specific antibodies, and that is when she was okayed for transplant surgery.
Induction.
Sir, she was given ATG for induction.
Okay, fine.
Yes.
So, what is the most probable cause? You think it's a rejection?
Yes, sir. Most likely, sir, rejection, because, sir, she has low TAC levels. I'd like to think of, sir, acute cellular rejection as my first possibility. Although, sir, with husband being donor, sir, possibility of antibody-mediated rejection in immediate post-transplant period is also very high.
Okay. My question is, you're given ATG induction.
Sir.
Okay. Is there a possibility that it's more of ABMR as compared to ACR? Because ACR is usually slightly rare when you have ATG induction. Slightly rare.
Yes.
So what all biopsy findings are you anticipating in this patient now?
Sir, if I expecting, sir, antibody-mediated rejection, sir, there would be glomerulitis and sir, peritubular capillaritis. If I anticipate, and along with the C4D staining in the peritubular capillaries, with a positive DSA levels.
Okay. Okay. So your approach is going to be you'll do a kidney biopsy.
Yes.
Okay.
Yes.
Before doing a kidney biopsy, could you even try increasing the dose of tacrolimus and see?
So, but sir, with rejection, sir, actually, her dose of tacrolimus, they had not been building up throughout the post-transplant period, sir.
Okay.
So she was already on.
My second question is, now this lady had a course of gestational hypertension, 2014, yes, 2017, 2017 onwards till 2018, she had an increase in creatinine.
Yes, sir.
That creatinine further increased.
Yes.
Could it be chronic TMA? And sir, now she has developed, she's developed a TMA again, immediate post-transplant. Could it be a possibility?
Sir,
if yes, then what are the markers which you are going to look for thrombotic microangiopathy in such a patient?
Sir, for thrombotic microangiopathy, sir, we look for the evidence of hemolysis, that is in the form of peripheral smear. We want to check for schistocytes, LDH levels, and haptoglobulin levels.
Very good.
Also, sir, evidence of thrombocytopenia
Hmm.
on the biopsy, sir. And
Okay.
sir, renal dysfunction.
And renal dysfunction.
Yes.
Fine. Sir, questions from your side, sir?
Right. Fine. No questions.
Okay. How do you differentiate between a thrombotic microangiopathy due to a CNI as versus due to ABMR?
Sir, there would be sir C4D staining in case of ABMR.
Okay, very good.
Chronic TMA.
Hmm.
The clinical. Don't jump to biopsy. Clinical differences.
Sir, I don't answer this question.
Chalo, padhoge?
You have already told low thrombocytes, cystocytes, features of hemolysis.
See,
So
your
on routine monitoring, you are doing all these things. They will not be there in cyclosporin toxicity or CNI toxicity. Okay, Abhishek?
Abhishek, it is usually localized. In case of CNI induced, it's usually localized.
Okay.
Whereas in case of ABMR, it will be slightly florid. Okay, and then you'll have features of C4D positivity. Okay.
Yeah.
Chalo, aage chalo. Past history.
So past history, sir, there is no history of diabetes, heart disease, stroke, seizures, or coughs. There is no past history of any AKI. There's no hospital admissions prior to 2014. Sir, personal history, sir, she's a homemaker with married for 8 years with 2 kids. She has normal bowels, a urine output, and her current urine output pre-transplant was around 200 ml per day. There are no addictions, no history of smoking, alcohol, or any other addictions. She is a vegetarian by diet, and she had normal caloric intake both pre and post morbid, and she has normal sleep pattern. There are menstrual and OBS history, that she obtained menarche at 14 years of age, and she had regular cycles with normal flow. However, she has been amenorrheic since the onset of hemodialysis. OBS history, so she's a para 2 with live birth 2 and nil abortions. Sir, family history, sir, she's a second child from a non-consanguineous marriage. Both her parents are diabetic. Her mother is also hypertensive. Her elder brother, is 4 years elder to him and has been hypertensive for past 7 years and has a history of AKI, which was attributed to NSAID intake. Currently, her renal function has been stable. So the husband is the donor, and he's a healthy 36-year male with no comorbidities. The drug and treatment history, her drug history, sir, prior to transplant, she had been taking injection darbepoetin weekly and iron injections every month, along with the Shelcal and vitamin D capsules every 2 weeks, and was on 2 antihypertensives, amlodipine and bisoprolol.
Okay. Abhishek, suppose this lady had lupus nephritis.
Yes.
Okay, lupus.
Yes.
And she presented with hypertension.
Yes, sir.
What urinary feature will differentiate between hypertension of lupus versus chronic hypertension leading to all these things? Or maybe I'll take preeclampsia. You take preeclampsia versus lupus.
Yes,
Okay. Hypertension
Sir.
due to lupus. In such a patient, what feature will you differentiate?
Sir, presence of RBCs or WBCs.
Active urinary sediment.
Yes, sir.
Is seen in.
Sir, lupus nephritis.
And preeclampsia, will you say it?
No, sir.
No. Very good. Chalo. Second question is, what happens to uric acid in a case of chronic hypertension vis-a-vis preeclampsia?
Sir, so pre-eclampsia, the uric acid levels, they tend to they rise, and especially in the later half of pregnancy,
Very good.
and they are actually used as predictors of fetal morbidity.
Very good.
Also.
There is in chronic hypertension or gestational hypertension will not have high
High.
uric acid. Sir, इसको तो सब कुछ आंसर आते हैं सर. चल, good, excellent. Carry on.
Sir, moving to examination, sir.
Yes.
Sir, on examination, sir, the patient is conscious, alert, cooperative, lying comfortably in bed. She is average build. She has a height of 162 centimeters, a weight of 83 kilograms, with a BMI of 31.4 kilogram per meter square. Vital signs: pulse is 88 per minute, regular, normal in volume and character, with no radial or radiofemoral delay, and all peripheral pulses are palpable. Blood pressure in the right arm in supine position was 146 by 86 millimeters of mercury, and on standing was 136 by 80 millimeters of mercury. In the left arm in supine position, it was 144 by 86 millimeters of mercury, and in the left leg was 154 by 96 millimeters of mercury. The respiration is 18 per minute, regular, and thoracoabdominal. Temperature on examination was 98.6 degree Fahrenheit oral. Sir, on general physical examination, she has pallor. There is no icterus, cyanosis, clubbing, edema, or lymphadenopathy. The JVP is not raised, and there are no dilated neck veins. The skin, hair, and nails are normal. Sir, CBS examination, sir, there are on examination of the precordium, there are no scars or any visible pulsation. Our apex beat is present in the fifth intercostal space, just lateral to the midline, and it is sustained in nature. There are no parasternal heaves or palpable P2. On auscultation, both S1 and S2 are heard and normal, and no murmurs or S3 or S4 are heard. Examination of the chest, so it is symmetrical in shape with no OD abnormalities. The bandage is present in the right infraclavicular region. And there is no redness or tenderness to palpation over the tunnel side. The percussion note is dull in all lung fields, and there are bilateral vesicular bronchial death sounds heard throughout with no adventitious sounds. On the examination of per abdomen, sir, bandaging is present in the right lumbar region, extending up to the hypogastrium. There is no drain. The per abdomen is symmetrical, and all quadrants move equally with respiration. Umbilicus is midline, and there is mild tenderness to palpation of the surgical side. There is no organomegaly. So CNS exam, higher mental functions, cranial, motor, and sensory systems are normal. So reflexes are normal. On fundus, sir, I could not find any evidence of retinopathy.
Okay.
No retinopathy?
Yes, sir. I could not see
Abhishek?
any. There are no cotton wool spots or flame-shaped hemorrhages. I cannot make out, sir, AV nicking or.
Did you see it, or why?
I saw it, sir, but
Because
I don't know. I looked for
because
it.
do you expect a person who is having
No, sir.
hypertension for last so many years,
Sir, at
and
least sir,
there are no changes in the eye?
no, sir.
So if you are not clear, don't have take it. So this is called foot mouth disease. There was no need. अगर examination किया है ठीक है, otherwise नहीं.
ठीक है. So Abhishek, what is just summarize and give your possibilities in this case?
Sir,
How will you summarize and give a diagnosis?
Sir, a 32-year female with gestational hypertension in first pregnancy 7 years back, with loss to follow-up, and chronic hypertension in second pregnancy with likely superimposed preeclampsia in the third trimester, leading to a LSCS with a normal weight baby, with a biopsy-proven advanced kidney disease postpartum, with no history of proteinuria, hematuria, any systemic symptoms of past UTIs or drug intake, with progressive decline in renal function over 2 years, culminating at stage 5 disease, with dialysis through a tunneled right IJ catheter, complicated by intradialytic hypertension, likely secondary to volume expansion, and one episode of catheter-related bloodstream infection managed with antibiotics. She underwent a live-related donor kidney transplant, with donor being husband and ABO compatible, on the 7th of January, with no perioperative or immediate post-operative complications, with acute graft dysfunction on post-op day 7.
Okay.
So what is your, sorry, what is your possibility for acute graft dysfunction? And one thing, did she have biopsy yeah, before she was started on dialysis?
Yes, sir. She was biopsied after her second pregnancy, sir, when she was told that she has advanced kidney disease and was put on antihypertensives and nutritional therapy.
So, but they did not specify what it is,
Yes, sir.
what kind of,
She
is
knows
what
that she had IgA
glomerulonephritis or interstitial nephritis, or if they have, where was the biopsy done?
So this was done in sir, Fortis, Shalimar Bagh.
Okay.
No, he's got the diagnosis of IgA nephropathy, sir.
Yes, sir.
Okay.
He was told
So it was IgA nephropathy.
IgA.
Okay. So now, what are the possibilities for this acute graft dysfunction?
Sir, the acute graft dysfunction, sir, my first possibility would be rejection. So secondly, it can also be due to infection, because she had a tenor catheter and has a past history of catheter-related bloodstream infection.
So it was catheter-related infection or UTI also?
Yes, sir.
Because
UTI
you are
can
saying
also be
there was
possible
quite pain in the operation area,
Yes.
and her catheter was recently removed, or was she on catheter?
Sir, her catheter
When
was
she
removed
developed this,
after on post-op day 7 itself, sir. Not
So graft pyelonephritis, early graft pyelonephritis is a possibility.
Yes. Rather than CRBSI, I would say graft pyelonephritis would be your possibility. Okay. So one is acute rejection. Second, graft pyelonephritis, or you say infection.
No.
So in infection, you are saying graft pyelonephritis. Any other possibility?
Sir, usually, sir, in post-transplant period, sir, although she has no history of any volume depletion.
Not in this patient. Suppose this patient, you have already told TAC levels were low.
Yes.
And based on these things, worsening of hypertension, TAC levels being low, and graft dysfunction, you are keeping rejection as the first possibility with a DD of infection. Suppose we are not considering this patient. So otherwise, graft dysfunction at day 7, what will be other possibilities besides these two?
Sir,
which
can
you
we
will
do,
think
sir,
of?
volume depletion?
Okay.
Also, sir, patients can have frank acute tubular necrosis. Then, sir, surgical complications. Sir, there can be a urinary leak or sir, any hematoma which can cause compression of the graft or ureter.
What about CNI toxicity?
Yes, sir.
That
Yes,
is
sir.
why that will be the number one after these two conditions: CNI toxicity, okay, volume depletion, and frank ATN. Why are you saying if a person has got good urinary urine output and renal functions came down to 0.8? So unless it is now secondary event, some hypotension or infection, then person develops ATN. But otherwise, it is unlikely. But again, what Dr. Dogra had asked you earlier, TMA, because that is a very important thing, what he had asked you earlier. And anything about SLE you have already discussed, there is the unlikely chance, because at times Epla syndrome, they can just come with hypertension during pregnancy. and if person has not been evaluated fully, might have been missed. Okay, so the question which Dr. Dogra asked you, what will you find in the biopsy? Likely to find in the biopsy, and how would you treat this patient?
Sir, because if her TAC levels are low and she has been, sir, if there is a possibility of ACR, sir, then sir, she will have inflammation in her tubules, and sir, inflammation will be.
We are not talking theory.
Yes.
So, what will you find in this patient on biopsy, or what you feel that these will be the findings, if and not?
Sir, tubulitis, interstitial inflammation. Sir, there can be intimal arteritis as features of acute cellular rejection. Otherwise, sir, if she has AMR, sir, she can have glomerulitis, peritubular capillaritis, along with, sir, C4D staining of the capillaries.
So, can you talk like this, that I look at the tubules, interstitium, glomeruli, and the vessels? So, tubules, any features of ATN, peritubular presence of tubulitis, capillaritis, any hemorrhages or infarcts in the glomeruli. Okay, so and then C4D staining.
Interstitial inflammation
Yeah.
can be seen. Okay.
Yes.
Thrombi can be seen.
Yes, sir.
Okay.
Yes.
Okay. Do you
So
remember
now-
Bamf classification?
Sir.
Do you remember Bamf classification?
Sir,
2008.
Bamf, sir, Bamf classification, sir, modified in 2017. Sir, it is used to classify and grade rejections in transplant. Sir, class 1 is a, sir, normal biopsy. Sir, class 2 is used to define active antibody mediated rejection. Sir, the criteria used that in Bamf is, sir, patient should have evidence, morphologic evidence of tissue injury along with immunologic evidence, and DSAs or any equivalent test. Sir, for morphologic evidence, sir, patient can have glomerulitis, capillaritis, sir, TMA or ATN, which cannot be explained by any other cause. So for immunologic evidence, there should be, sir, C4D staining in the periglomerular capillaries and an evidence of donor-specific antibodies in the serum. Sir, the glomerulitis is graded into G0, 1, 2, and 3, and sir, the peritubular capillaritis also graded into 4 grades. Sir, for glomerulitis, sir, 0 means, sir, no, and sir, 1 means, sir, less than 25% of glomeruli, sir, are involved. And sir, G2 is 25 to 50%, and sir, I think G3 is, sir, sir, more than 50%, sir. Sir, sir, for peritubular capillaritis, sir, inflammation in capillaries with P0 is, sir, PTC 0 is no inflammation, sir. PTC 1 is 1 to 4 cells, mononuclear cells in any peritubular capillary. PTC 2 is 5 to 10, and PTC 3 is, sir, more than 10 cells. So this is for classification of AMR. Sir, for ACR, sir, we use interstitial inflammation, tubulitis, and intimal arteritis. Sir, lesions are again further divided into I0, I1, I2, I3, and T0, T1, T2, T3. Sir, to classify
PCMR 1A.
I'm sorry, sir.
PCMR 1A. 1A.
Sir, TCMR 1A is sir any sir I2 plus T2 lesion is
Very good. 1B.
1B is sir I2 plus T3 sir.
Very good. I2 or I3 with T3.
T3.
उसमें I2 or I3 with T2.
T2.
Okay. What about 2A?
So 2A is sir intimal arteritis, that is a V1 lesion,
Very good.
and T2 is sir V2 lesion, and T3 is sir occlusion of the entire vessel.
Okay. Is there any relation of if we take 2A, 2B, or 3? Is there any role of I and T in that?
Sir, to classify as ACR, sir, we need at least I2 and at least T2 to classify the rejection as ACR, sir.
Okay. The what Bamf classification says, regardless of the I and T, if there is V1 or V2 or V3 lesion, so naturally the it becomes 2A, 2B, or 3.
3, sir.
Okay.
Yes.
चलो ठीक है. Sir, I too don't have any more questions, sir. He has answered most of the questions.
Yes, yes.
You know?
So, okay, Abhishek, this patient has acute cellular rejection. Okay, how would you treat now?
Sir, for acute cellular rejection, sir, we give a pulse dose of methylprednisolone as 3 to 5 mg per kg with a maximum dose of 500 mg for 3 days. Sir, in case if on biopsy, sir, this is a lesion either showing T3 lesion or it is grade 2 or grade 3 lesion. It is also recommended to use ATG, sir, in the dose of 1 to 3 mg per kg.
The patient has already been induced. You are saying she has received induction.
Yes.
And you are thinking there is differential diagnosis of infection.
Yes.
And then what will you do? Which will be the safer option?
Sir,
after giving steroids, pulse steroids?
Sir, we like to upscale our antibiotics and then use pulse steroids and sir, watch for decline in.
What about plasma?
Sir, cellular rejection, sir, there is no role of plasma exchange.
So you will give pulse steroid and hike up the CNIs. Hike up the CNIs. Okay. And suppose now this is ABMR. Because she is a high risk transplant.
Yes.
Husband has donated. So this is ABMR. The C4D more than 75% glomeruli are showing. DSA, okay. We have not done it, but DSA is also normal. But you have two criteria.
Sir, for
C4D and other features of.
Sir, for AMR again, sir, as
immunosuppression of AMR.
Sir?
Sure short treatment of AMR. Recommended sure short treatment.
Sir, methylprednisolone 500 mg OD for 3 days, along with sir plasma exchange, which is sir 6 exchanges, and followed by IVIG. So plasma exchange, the initial is 1.5 volumes of plasma, followed by the next exchanges of 1 volume of plasma, and IVIG as 100 mg per kg after each plasma session.
Okay. And plasma exchange, will you give daily or?
Sir, alternate days.
Alternate.
Okay. What is the role of rituximab versus bortezomib?
Sir, rituximab, sir, it is indicated in patients who have sir vascular inflammation. Can't please.
तो ये दो चीज पढ़ना, ठीक है? Role of bortezomib, role of rituximab.
Yes.
Okay.
Yes.
What is the role of ATG in ABMR? ATG acts. What all cells does ATG suppress?
Sir, basically, sir, T lymphocytes, nave, and activate T
Some action
lymphocytes.
on B lymphocytes also. Okay.
Oh.
And bortezomib is usually what the previous literature you say was that bortezomib is for anti-HLA antibodies. But over a period of time, people have been using rituximab because it's much more broad spectrum drug. Okay. How will you monitor the patient for infections post ATG? Now I'm talking about suppressive treatment versus definite treatment with valganciclovir. How will you monitor the patient?
Sir, monitoring patient. Sir,
Yes,
sir,
monitoring for after such a high immunosuppression, what all viral infections you will be monitoring.
sir, it is sir, valganciclovir is recommended for patients who are given ATG for at least 100 days of treatment of prophylactic treatment of valganciclovir on patients who receive depleting
Dose.
Other school of thought.
Hmm.
See, you give 100 for 100 days you have given.
Yes, sir.
And sir was asking in which dose?
Sir, it is 450 milligrams per day.
Okay. And what is the other way you can manage patients for suspected CMV? You expect CMV to occur, right?
Yes, sir.
So how will you monitor? Will you give it to everyone, or there's another possibility which you can do?
Can you check for the seroconversion?
So there are three methods: prophylactic, preemptive, and after diagnosis of CMV. So monitoring you will be doing if you are not giving prophylactic, so you are going for preemptive, and that is why you are doing monitoring. So how frequently you will monitor? And what other viruses will you be monitoring?
Sir, the
BK
patients-
virus.
Actually,
BK virus.
Yeah, BK virus, which
Yes,
you
sir.
should actually monitor
Yes.
after transplant. Okay, so
Because usually you do not give any prophylaxis for BK virus, but you have to monitor if a patient has been induced with polyclonal antibodies, or after rejection you have given them high dose immunosuppression. So you must always be monitoring. And what is the protocol? Okay, you read that.
पढ़ लेना है. दोनों चीजें important है. You just have a look on that.
And 100 days versus 200 days. Again, there are studies. You can see whether there is advantage of giving for 200 days or 100 days is enough. Okay. What other things you will give?
Sir, prophylaxis with 4-trimoxazole is routinely given
Yes.
for
PCP
prevention of
prophylaxis.
PCP and listeria, nocardia.
Okay. Is there any role of prophylaxis for BK virus? Some people used to give levofloxacin. So fluoroquinolines as prophylaxis for BK?
Sir, neither fluoroquinolones nor defenamide have shown to have any role in prevention of.
Okay. Because there was a time in around 2016 that people used to give, but on follow-up it has been seen that there is no advantage of giving prophylaxis.
Sure. Abhishek, I'll ask you one question. This lady is of I heard basic disease of IgA nephropathy.
Yes.
Okay.
Yes.
Now, suppose she has after maybe duration of 2 years, 2 years maybe after transplant,
Yes.
he has acute rise in creatinine.
Yes.
Okay.
Yes.
She has acute rise in creatinine. Her baseline creatinine was suppose 0.9. Now it's increased to suddenly 3, 4, 5. What your possibilities would be after 2 or 3 years of transplant?
Sir,
A rapid rise in creatinine.
Sir, it could be sir, due to a recurrence of de novo disease, recurrence of IgA nephropathy. It could be sir.
पहले common तो rejection रहेगा ना,
Yes.
है ना?
Yes.
So commonest in common rejection रहेगा because there's a rapid rise in creatinine.
Yes.
Okay. What other thing can cause rapid rise in creatinine after around maybe 2 years?
Sir, infections.
Very good. Infection or
Sir, BK virus.
ठीक है. Or
Then sir, recurrence or
yes. What kind of recurrence will cause such a rapid rise?
sir, if a patient has a crescentric
Very good.
IgA.
Yes.
So suppose it's a crescentric IgA which recurs.
Yes.
How will you manage the patient?
Sir, again, because of management of crescentric IgA is sir, pulse steroids and sir, pulse steroids and sir, plasma exchange.
Is there any role of plasma exchange in crescentric IgA?
No, sir.
Yes.
पढ़ोगे ये?
Yes, sir.
सोचना है इसके बारे में, पढ़ना. ठीक है? सर मेरा कोटा तो खत्म हो गया सर.
I think he has done fairly.
Answered most of the questions, sir.
He has.
Good.
और क्या पूछे हैं? He has done.
He's done well, sir.
He has done well.
Did.
But this result is from your side, ki how he has fared, and
He fared well, sir. But we say the common things, na, he has to brush it up again. Those 100 days versus 200 days, monitoring of CMV, okay, diagnosis. He's answered most of the questions, sir. He's been well trained. But we said that he has to answer slightly more on these aspects. Okay?
that is true. That is true.
But you done well.
Thank you,
sir.
Bilkul. So your assessment is by Dr. Dogra, and I might have been biased. That is why Dr. Dogra's comments and his result is definitely that you just brush up with few things. And again, your history, it should be little bit summarized. And the way Dr. Dogra told you, you have to highlight certain things. I have asked about DSA, cross match and this thing, because at times with a lengthy history, examiner also goes into nap and he might miss. Even if you have said all these things. Okay. I think that is good.
He's been well trained, sir. Congratulations, sir.
Thank you so much.
Thank you,
And, these are really good people. I think we have got all good peoples. All over Delhi, I think we have good people. Yes.
Thank you, sir.
It's an honor, sir.
Thank you. Thank you so much.
Taking exam with you, sir.
Thank you, sir.
Dogra,
Thank
that is
you.
why I wanted
So
you
the
should
faculty
take
of Delhi,
exam.
so nice.
And I really enjoy Dr. Dogra taking bedsides with you.
Thank you, sir.
Thank you.
Good
And
evening,
good
sir.
night.
Thanks, sir. Thank you,
Thanks a
Abhishek.
lot.
Thank you, sir.
Thank you.
Thank you so much.
It's a pleasure of students to have such fans. Thank you.
Any question from the students? Okay. No, huh?
No, sir. I mean, no history of blood transfusion, sir. I had forgotten.
Somebody had asked this question.
Yes, sir.
And any questions from the audience, other DNBs? No questions? Chalo. Okay, Abhishek. Good.
Thank you, sir. Thank you, sir.
Thank you, sir.
Okay, Puneet.
Thank you, sir. Thank you so much.
Okay, good night, Puneet. Good
Thanks.
night. Okay.
Good night.